بسم الله الرحمن الرحيم. GI bleeding. We have the types of GI bleeding: upper, lower, or occult or obscure. Upper and lower means the above ligament of striates or distal to ligament of striates, which is the end of the junction between the duodenum and jejunum. Occult means it is maybe iron deficiency anemia or occult positive stool. Obscure could be occult or it could be plain overt bleeding that we cannot know whether it is the upper or lower. But this can have been classified also into upper or mid-gut or lower after the invention of the capsule endoscopy and enteroscopy. So we can detect now the mid-gut bleeding. So upper GI bleeding from the mouth to the ampulla of water, mid-gut bleeding, which is from ampulla to ileocecal valve, lower, which is the colonic distal to ileocecal valve. The upper, and also the main causes are some endoscopic pictures for that. This is esophagitis of the extensive esophagitis. This is an ulcer with a blood clot on the ulcer of the duodenum. And this is an ulcer in the duodenum with visible spots. This is carcinoma of the body of the stomach, and this is carcinoma of the cardia of the stomach. This is a large hiatal hernia with two malleolar waist hairs, and this is AV malformation in the antrum of the stomach. What to do for such patient? The first step is resuscitation, stabilization, and then endoscopy, whether diagnosis and therapy. The first group of bleeding, as we said, this is the portal hypertension upper GI bleeding. This is the cirrhosis will have an increased resistance in the portal flow inside the liver. That will cause the portal pressure to increase, causing portal hypertension. The portal hypertension, as a trial to decrease it, there will be a splanchnic vasodilatation to decrease the arterial resistance, but after this dilatation it will increase the portal blood flow, and this portal flow will increase more the portal hypertension, and it will be a vicious circle to form varices, and the varices with time will grow. So it will grow, and this is the endoscopic picture, esophageal. This is the esophagus with no varices, while these small varices, and here there is large varices, and from going from no varices to small varices, or from small to large, you need to have a 7 to 8% per year. This is the rate of progression. After the growth of the varices keep growing, so it will rupture, and it will rupture, it will cause upper GI bleeding. There is some predictors of hemorrhage we can detect by endoscopy, as well as the variceal size, which is above 5 millimeter if it is large, or if there is red signs like those, or if the patient has advanced liver disease, child B or C. So by endoscopy, you can diagnose the varices are there or not, whether it is large or small, and whether there is red white signs or not, and you can then predict the bleeding, and you can initiate what they call primary prophylaxis, which is trying to prevent the patient from the first bleed. But if the patient bled, then you treat the bleeding by endoscopy, as we will see, and then try to prevent it from recurrent bleeding after that, and this is called secondary prophylaxis. The size of the varix, there's many ways to classify them, but as we said before, the small or large, or this is one of the classification, the Paquet classification, which is putting it in 4 grades, 1, 2, 3, 4. If it is less than 25 of the circumference, it will be 1. From 25 to 50, it will be 2. Above 50 to 75, 3. Above 75, it will be 4. So the endoscopy, you can predict, as you said, by presence of Bridwell signs or not, the vessel are large or not, and whether the child C or B, as we said. And all of those has been put in an index called Dick index. the child class, the varicella size, and red whale marks, and then you can predict whether if the patient has low score, the chance of bleeding is low. If they have a high score, the chance can get as 70%. The primary prophylaxis, which is the standard treatment to prevent the patient from the first bleed, and this is the use of non-selective beta blockers. If the patient responded, the patient is called hemodynamic responder. You can measure the HVPG, hepatovenous pressure gradient, which is less than 5, no portal hypertension. Above 5, it will be portal hypertension. Above 10, it will be the presence of varices. Above 12, the varices will bleed. So we try to make it around less than 12 to prevent the patient from bleeding. Or you can measure it also by the diminish of 20% of the original, or usually by the basal heart rate. You can measure basal heart rate, and then after the treatment, if decreased by 20%, that means the patient responded to the beta blocker. If the patient responded, chance of bleeding is very low, and the survival is better, and if did not respond, the chance will be as high as 70%. The patient could die, could bleed from this varices. What about if the patient is sensitive to beta blocker, or have contraindication to beta blocker, or if he is hemodynamic responder, then you will go for variceal ligation. The bleeding, of course, depending on the size of the varix, as we said, the tension in a physical equation, as you can see here, but the variceal wall tension is the major determinant of variceal rupture and depends on the pressure and radius and the wall thickness. If it bleeds, it will be bleed like this. So this is the varix, a lot of blood inside the esophagus, and this is bleeding. If bled, so it is in the first 24 hours, the patient will have chance of survival will drop from 100% to around 50%, and to continue to have so for the next 30 months. So the chance of effective treatment will be in the first 24 hours. You can save a lot of people, but if you waited more than 24 hours, then it will be almost the same. What our principal goals of our management of portal hypertension or bleeding from portal hypertension: to prevent the first bleed, primary prophylaxis, to control the acute bleeding, and then to prevent the second bleeding, which is the secondary prophylaxis. The principle of management is trying to reduce the blood pressure using pharmacologic therapy, or sometimes surgical like shunt, or interventional shunt like TIPS, we'll talk about in a minute, or you can also control by local management for obliteration of the varices. We will see temporary, which is balloon tamponade, or endoscopically by sclerotherapy or band ligation. You can also know the severity of the bleeding by measuring the hemoglobin, whether there is anemia or not, whether the patient is stable hemodynamically or not, whether they have infrequent bleeding or coffee ground hematemesis. It will be mild, but if he has hemoglobin drop more than 2, anemia less than 10, hemodynamically unstable, repeated hematemesis, or even large volume of bleeding causing even hematochezia, this is called severe. So you can know by the manifestation of the patient, clinical presentation of the patient, whether he is mild or severe, and then we will manage. This is the weapons you have: pharmacologic therapy, somatostatin, or octreotide, which is somatostatin analog, or terlipressin, which is vasopressin analog, and this is the most effective of the three. Then balloon tamponade, which is sangustatin, as you said. This is a bridge therapy or temporary use for 24 hours and take it out. Or endoscopically, as we will see, the endoscopic variceal ligation or sclerotherapy. TIPS, which is transjugular intrahepatic portosystemic shunting, or surgery, which is the shunt or transplantation. How this will occur: if the patient is expected to have variceal bleeding, then resuscitate. If the patient hemodynamically stable, go for endoscopy. But if he is not stable, pharmacologic therapy first. If he is stable, then you go for endoscopy. If he is not stable, then balloon tamponade for less than 24 hours, and then if he's stable, you will go for endoscopy. If unstable, you will go for either TIPS or shunt, or go for the liver transplantation. But if the patient going for hemodynamically stable, we will see whether he is having a variceal bleeding or non-variceal bleeding. If he is variceal, you will go for sclerotherapy or variceal ligation. If the patient controlled, then you should repeat till variceal eradication. If uncontrolled, then you will go for TIPS or shunt or transplantation. Endoscopic therapy, this is the cornerstone of upper GI bleeding, and this is what we have. For esophageal varices, you have sclerotherapy or band ligation or tissue adhesive. Gastric varices and the other varices, you will have only the tissue adhesive. We'll talk about it. Sclerotherapy and acute bleeding, this is the treatment choice. If the patient has active bleeding, then you will inject the bleeding source, if you can see it. And you can be successful in around 90% of the time. Major drawback of the sclerotherapy is complication. This is the varix, and this is the site of the bleeding, and this is after injection, it has been swollen with the sclerotherapy material to stop the bleeding. Usually, this is the end treatment is after the injection, it turns to fibrosis and sclerosis of the varix. The complication usually minor, chest pain, dysphagia, sometimes fever, reactive pleural effusion or stricture, but there is rarely serious effects like bacterial peritonitis, perforation, mediastinitis, brain abscess, and all of that. And this complication, depending on how much you are injecting, and also on the patient. If the patient is having very severe disease, we have bad coagulopathy, cannot heal what you inject, then you will expect to be inject more and then more complications. And that's why it has been replaced by the endoscopic variceal ligation. And this is a cap with a lot of bands, and then you just suck the varix inside this cup, and then put bands around those small blebs or small balloon full of blood, and then thrombose, and a lot of blood will stop and thrombose, and then will slough with a small ulcer, and this small ulcer will heal, but the size of the varix will decrease, and then gradually it will completely obliterate the varix. The complication of band ligation is the same for sedation, but less for sclerotherapy, less stricture, less pulmonary infection, less other complications. Less complication, more effective, better in preventing rebleeding, but some people will say it is not suitable for active bleeding. Some will say it can elicit more recurrence than the fibrosed, sclerosed varix. Okay, you are successful and the patient stopped bleeding. If you just stopped there and didn't do anything, you will have a chance of 50 to 80% that the patient will have recurrence of the bleeding. And that's why the end point of the treatment is the obliteration of the varices. If you obliterate the varices, and there is no chance that it will bleed. But if you have persistent, even bluish, small varix, it will have a continued risk of bleeding. And that's why you continue to have every 2 weeks or a week or 2 weeks still eradication. And after the eradication, you have to follow up to prevent reappearance every 6 months. Why? Because around 15 to 20% they will have recurrence, and that's why we don't know the cause yet, but for that you will have a recurrence follow-up endoscopy at least for 2 years to prevent if there is recurrence, you will band ligate again. Failure of endotherapy could be definite, the patient inability to stop the acute bleeding, or if it is recurrent after bleeding obliteration, or there is recurrence in the same hospitalization. But most people will agree that if the patient have two bleeding episodes in the same hospitalization and you have endotherapy by experienced endoscopist and still bleeding, then that means there is failure of sclerotherapy. Most of the cause is due to it occurs in around 10% of the patient. Mostly they have gastric ventral varices or other varices, rarely portal hypertensive gastropathy. If this occurs, then you will go for the TIPS or surgery, which should be shunt or transplantation. The TIPS, which is the transjugular intrahepatic portosystemic shunting, then the wire will go from the transjugular through the heart, to the right atrium, to the inferior vena cava, hepatic veins, and this hepatic veins, you get a guide wire through the liver substance to the portal branches, and then balloon dilate this tract, and then apply a stent that it will be passing from this systemic to this portal circulation, so it will be as an intrahepatic portosystemic stent shunt. The stent is better than endotherapy, but the problem is the cost as well as the temporariness. That because it is temporary, it will be for 5 years, and after that, if it could be blocked, and if blocked, you need either to reinsert it or otherwise the patient will bleed again. Endoscopic therapy compared to distal renal shunt, which is the surgery, the endotherapy is better. What to tell your patient? If the patient having a child class A, then you can ask, you can take his opinion whether to go for band ligation or to go for shunt surgery. This is the only patient that you can judge whether he can go this or that. And if he rebleed, you will go for TIPS or shunt or transplantation if you didn't do it from the beginning. But if he is B or C, endoscopic ligation first, and if he is rebleed, you will go for TIPS or shunt. So to review that, if the patient having no varices, you try to prevent it by primer prophylaxis, no, because this is called the pre-primer prophylaxis, that is before formation of varices, and there is no specific therapy. You should repeat endoscopy in 2 to 3 years if there is no varices. If the varices start to show, then you will prevent the first varicose no hemorrhage, prevent the first varicose hemorrhage, which is the primary prophylaxis. If you primary prophylaxis, this will prevent the variceal growth by repeating endoscopy and beta blockers. And if the patient will respond to beta blockers with primary prophylaxis by propranolol, nadolol indefinitely, or if they have a patient having a sort of sensitivity or non-hemodynamic is non-sensitive or hemodynamic non-responder or whatever, then you go for endoscopic ligation. If the patient bled, then you control the hemorrhage and then try to prevent the recurrence of hemorrhage by repeated endoscopy till eradication. This is for the esophageal varices. What about the other varices, which is the gastric varices? Gastric varices, this is large varices, as you can see, this is the fundus of the stomach. And it could be classified according to the Sarine. This is the most common, is the Sarine classification, which is isolated gastric varices type 1, if it is in the fundus. If it is in the antrum, it will be called isolated gastric varices 2, IGV2. Or if it is continuous from the esophagus, it will be called gastroesophageal varices type 1 in the Risser curve. If it is in the Creter curve, it will be gastroesophageal varices type 2. So this is a sort of phenotypic presentation for GOV, IGV 1, 2, and then others. This is the large gastric varices, you can see. This is the linear type. This is the large gastric, as you can see. Isolated gastric varices 1. And this is isolated gastric varices 2 in the antrum. Also, you can see it in the duodenum. or rarely in the, this is duodenum also, and this is in the rectum. Why the treatment of gastric varices is peculiar? The pharmacologic treatment and beta blocker response are the same, but you cannot use sclerotherapy. Ulceration will occur and the patient will bleed from the sclerotherapy. And also you cannot do band ligation, it will slough and the patient will bleed like hell. So the only option you have is the tissue adhesive. Also, what is peculiar, if especially in the gastric fundal varices, gastric varices type 1, is the large percentage of bleeding. This is above 80% that the patient will bleed from gastric varices if it is isolated, while if it is in the GOV1 or GOV2, it is larger, more or less moderate chance, more than the esophageal a little bit. Also, what is peculiar is the isolated gastric varices that occurs alone, without portal hypertension, without, esophageal varices or cirrhosis. And this can occur in splenic vein thrombosis, and the treatment for this is splenectomy. This is the only way that splenectomy will cure this varices. Otherwise, it will increase any other varices. So what is peculiar also is the treatment of the gastric varices. It is not sclerotherapy or band ligation. It is tissue adhesive. You inject a material like Amir Alpha. You go inside the varix and it will turn it into a lot of foreign body material. It will be hard, and then you can check after injection that it is hard, and it is injecting the material you inject, and you can follow up endoscopically this hard tissue till it will heal. You can endoscopically follow them, or you can even radiologically, because it is fat soluble material. You can put on it lipidol, and you can see the large varices in the fundus, and you can follow them till by perforated X-ray, and this is the same patient after 6 months. So variceal obliteration is suspected, then hemorrhage is suspected. Initial management is transfused to hemoglobin around 8, not more, because more than 8, the over transfusion will cause bleeding. Early pharmacotherapy, and then antibiotic prophylaxis for any GI bleeding, because it will improve actually survival, decrease mortality and improve survival. Variceal obliteration by tissue adhesive is possible and bleeding controlled, then you continue the patient on beta blockers. But if it is not possible, you will go for TIPS or shunt. Next point in portal hypertension is portal hypertensive gastropathy. This is endoscopic picture for those. If it is mild, it is called have like a mosaic pattern appearance, or chicken wire appearance, or snake skin appearance. If it is this mosaic pattern plus hemorrhagic spots, it is called severe. And also the severe is where it is GI loss, and the treatment usually by beta blockers, and if not effective, you go for TIPS. But sometimes endoscopically you have something called GAVE, which is gastric antral vascular ectasia. It is like the severe portal hypertensive gastropathy, but occur more in the antrum. The portal hypertensive gastropathy occur more in the fundus and body and distribution. So proximal, this is distal in the antrum. And the mosaic pattern appearance is present in the portal hypertensive gastropathy, but not in the GAVE. Red sign present in both. If you still have dilemma, take biopsy. If there is thrombi, it will be GAVE. The treatment of GAVE is usually APC, which is argon plasma coagulation. Portal hypertensive gastropathy, as we said, usually occur bleeding. Acute bleeding is very rare, and you could put the patient on beta blockers, as you can see. And if the patient transfusion dependent, you can go for TIPS if they are not, beta blockers are not effective. What about the non-variceal bleeding? This is the second category of upper GI bleeding, and this is the peptic ulcer, GERD, tumors, Malheur-Weiss, formation de la Foy, and the same, you will go for management, acute management, resuscitation, stabilization, and then endoscopy and diagnosis and therapy. But what is important is you should look at the base of the ulcer, because at the base of the ulcer, if it is clean base, the chance of rebleeding is less than 10%. This is clean base ulcer. If there is flat pigmented spot, this is less than 20, around 15%, and those they do not need endoscopic management. But if you have an adherent clot, then this chance of rebleeding is around 30%, and this you can inject and see whether the clot is stable. If it is stable, that's fine. If it is not stable, it will be either way. It will be a visible spot inside, it will be removed, and under this will be visible spot, or like this will be visible vessel. If there is visible vessel, the chance is around 80%. If there is actually oozing or spurting, the chance of, if it stopped even, it will be around 90-95% to recur bleeding. So for those, you need to endoscopically manage. What to do endoscopically? You can use probe, coagulation, sclerotherapy, injection, band ligation, APC, argon plasma coagulation, or laser, or clips. And this is the first possibility. This is the ulcer. This is the visible spot. You see, you note that the bleeding source will be a little bit proximal to the vessel, actual spot you see. So you need to intervene in this area. If you intervene by injection, you inject by here, cause compression of the feeding vessel, or you can go by coagulation of the feeding vessel as well as compression, or you can go by clipping the edge, proximal as well as the distal edge of the feeding artery, and this will cause a stoppage of bleeding. Or you can go by argon plasma coagulation to coagulate the ulcer base, and this is by coagulation. The next few slides will show you the summary of the consensus of recommendation. This is in up to date. You can get it from the library. I'm not going to talk in details for this, because this will be talked dealt with in the ulcer lecture, peptic ulcer lecture, because this is bleeding ulcer. So this is the same resuscitation, and then endoscopic management, we talked about it, and then pharmacologic management, and then after discharge, what you should do for those patients. Then the causes of lower GI bleeding. Lower GI bleeding, usually we have some peculiar causes. Diverticulosis, this is anatomical divertically of the wall, angiodysplasia, radiation-induced telangiectasia, as well as inflammatory like infection, dysentery, amoebic, bacillary, whatever, or ischemic colitis, or IBD, in addition to polyps, as well as carcinoma, or others like hemorrhoids. What is the percentage? The commonest cause is diverticulosis, 30%. Next cause is hemorrhoids, 10% around ischemic colitis and IBD. Post polypectomy and cancer around 8%, and the rest are rare radiation or angiodysplasia. This is divertically in the colonoscopy, and also this is endoscopy compared colonoscopy versus colonoscopy. Of course, colonoscopy showed better pictures. Carcinoma of colon, and this is the angiodysplasia of the colon, larger than those in the upper GI tract, and can cause significant bleeding, especially in old age. Inflammatory bowel disease, Crohn's disease, or ulcerative colitis can cause significant bleeding. And this is ischemic colitis, and it is endoscopically similar to ulcerative colitis, but in a localized area, and this area mostly in 50% of the cases in the watershed area, in the splenic flexure, descending colon, and sigmoid colon. Polypectomy can cause bleeding. Also, post-polypectomy will cause bleeding, but that's why we need to know to show the ulcer of the polyp after removal. It is clean and no spurting vessels or something like that. Radiation proctitis is usually due to radiation for gynecological malignancies as well as prostatic malignancy. If they have radiation, they will cause radiation of the rectum as well as urinary bladder and can cause proctitis and bleeding per rectum, and this is the endoscopic picture for that. How to diagnose lower GI bleeding? Usually you can use whether colonoscopy, RBC scan, or angiography, and usually depends on the rate of bleeding. If the patient is stopped the bleeding, you can do colonoscopy. Intermediate bleeding, you can go RBC scanning. If it's still bleeding, you can do angiography, CT angio as well as angiography. The RBC scan, it is not used anymore. It starts to be less fashioned because this technician RBC scan will go to the area of the blood bleeding. This is area here around the splenic flexure, and you with time it will accumulate and then go to here to the what's seem like rectum. So the bleeding will be continue and so on forth. So you can see splenic descending sigmoid as well as the rectum, so the bleeding will be here in the left. So it is crude, more less specific, less sensitive and specific than angio, because the angiography will show the actual vessel and even have the potential for coiling or injecting. So you have a therapeutic potential for the angiography to stop the bleeding cause from continue bleeding before going to surgery. What to do? Put an NG tube after resuscitation and then see if you find the cause, then you will treat it as we have seen in the ulcer: probe, coagulation, laser, APC, band ligation loops, and whatsoever. And after that, you will left with the occult bleeding. Occult bleeding, occult positive stools or iron deficiency anemia in men or in postmenopausal women, or if in perimenopausal women, if the gynecological causes are being excluded. What to do? Upper and lower. If they are negative, then you go for small intestinal causes, which CT, enterography, angiography, and capsule endoscopy and enteroscopy. What about obscure GI bleeding? Obscure GI bleeding means that the patient persists to bleed despite that upper endoscopy and lower endoscopy negative and radiologic evaluation of the small bowel, which is CT, enteroscopy, are negative. It could be occult, like the occult bleeding, focal occult blood positive or iron deficiency anemia, or could be over that you can see the bleeding but you couldn't recognize the source of the bleeding. And for the occult bleeding, for the obscure GI bleeding, could be upper. Usually sometimes you miss a Cameron erosion, peptic ulcer small, angiodysplasia, De La Foy, GAVE, or sometimes in the lower GI, angiodysplasia and neoplasm. But for the mid-gut, if the patient younger, Meckel's and then tumors. If the patient above 40, angiodysplasia. If the very rare to be hemophilia and other rare causes. What to do in those patients? If the patient obscure GI bleeding, you should do second look endoscopy, upper and lower. And if it is negative, then you will go for capsule endoscopy, angiography, as well as, if negative, enteroscopy. What occult capsule endoscopy showed have additional to us is that this is different pictures of the capsule endoscopy. Ulcer, this is meningioma, polyp, non-steroidal ulcer, Crohn's. Actually, two areas: the AV malformation and the Crohn's disease of the small intestine. Thank you.